I want you to imagine a surgeon mapping out this really high-stakes heist.
Okay.
And the vault they were trying to break into is the human liver. The target inside the vault is a tumor. But there is a massive catch to all of this. The security system, the hidden pathways, the electrical wiring, the plumbing, all of it is completely different for every single person.
Which makes it a pretty terrifying heist, if we were being honest.
Exactly. Welcome to today's deep dive. We are thrilled to have you with us today. We are exploring hepatocellular carcinoma, or HCC. It is one of the world's most common and, frankly, just most complex cancers.
Absolutely complex.
Yeah, and we are looking at this groundbreaking 2025 review article from the American Journal of Röntgenology, the AJR. It focuses on critical anatomy and how understanding the microscopic layout of a patient's liver is completely changing the game in treatment planning.
It really is a paradigm shift in how we view the human body. We are pulling from this fascinating stack of clinical and anatomical data today, drawing heavily on insights from the Stanford University School of Medicine and Tri-Service General Hospital. And in an era where we are just constantly bombarded with medical advancements, understanding the why behind these anatomical details is crucial. It is quite literally the difference between a successfully cured patient and a sudden catastrophic medical crisis.
Right. So the mission for today's deep dive is to decode that hidden, quirky plumbing of the liver. We are going to explore how doctors literally biohack the organ to make it grow on command. And we will understand why a single millimeter, just one tiny millimeter on a scan, can completely alter a patient's chance at survival.
It is wild when you put it like that.
It really is. So, okay, let's unpack this. We have to start with the rule book. Because in the world of liver cancer, doctors don't just guess what treatment to use based on a hunch, right? They consult this very strict algorithm. It is called the Barcelona Clinic Liver Cancer Staging System, or BCLC. How does this system actually govern what happens to a patient?
Think of the BCLC as the ultimate non-negotiable flowchart for HCC treatment. It stratifies patients into distinct stages from stage 0 all the way to stage D. And to place a patient in a stage, the system evaluates three main pillars. First is the burden of the tumor itself, so how big it is and how many there are.
Right.
Second is the underlying function of the liver, because these tumors almost always develop in livers that are already sick or cirrhotic. And third is the patient's overall physical status. The advanced imaging we are dissecting today primarily dictates that very first pillar, which is the tumor burden.
And from what I understand from the data, that rulebook just got a major update. The 2022 changes to the BCLC system seemed to send ripples through the medical community. What was the big debate they finally resolved there?
Well, the biggest point contention was how to classify a solitary HCC. Previously, there was a lot of dangerous ambiguity if a patient had a single massive tumor that was, say, over 5 centimeters. Some medical centers wanted to call that stage B.
Which steers them away from a cure.
Exactly. It steers the patient toward different, sometimes less curative therapies. But the 2022 update put its foot down. It explicitly classifies a solitary HCC of any size, as long as it is over 2 centimeters, as stage A.
Wow, so any size?
Yes, any size solitary tumor over 2 centimeters is stage A. That provides immense clarity for treatment pathways. Furthermore, the updates elevated a highly targeted treatment called Transarterial radioembolization, or TAR. Thanks to data from the Legacy trial, TAR is now officially recognized as a primary treatment for stages 0A and B, specifically for tumors up to 8 centimeters.
So the flowchart is getting sharper. It is adapting to the technology. But here is where it gets really interesting to me. I was looking through the liver transplant section in the data, and there is this incredibly stressful, counterintuitive rule. It is known as the wait and not ablate approach.
Yes, the 2-centimeter paradox.
Right, because if you or a loved one are diagnosed with cancer, your absolute first instinct is to demand the doctor take it out or destroy it immediately. But for liver transplants, you can't always do that.
It is arguably one of the most difficult concepts for a patient to digest. But structurally, the transplant system relies on it. In the United States, livers are incredibly scarce. They are allocated to the sickest patients first, using a scoring system called MELADE, the model for end-stage liver disease.
Which makes sense on paper.
It does. But the problem is many HCC patients have early-stage cancer, but their liver function hasn't deteriorated enough to naturally reach a high MELADE score. They would literally die of the cancer spreading before they ever got to the top of the transplant list. So to fix this, the system grants them exception points to artificially bump them up the wait list.
But to trigger those exception points, your tumor has to hit a specific size threshold, right? It must be between 2 and 5 centimeters. So think about the agonizing reality of this for a second. A patient goes in for a scan. The radiologist finds a tumor, but it measures 1.6 centimeters. That patient does not get the points. They don't get the transplant.
No, they don't.
Instead, they are put on active observation. They have to undergo this incredibly tense waiting period, getting scanned every 2 to 3 months, just hoping the cancer grows to that 2-centimeter mark, but hoping it doesn't spread anywhere else in the meantime.
The psychological toll is immense. And it is not without physical risk either. There is about a 10% dropout risk with this approach.
Meaning they get too sick to transplant.
Exactly. While the patient is waiting for the tumor to hit 2 centimeters, the disease could progress or spread in a way that disqualifies them from a transplant entirely. But you have to consider the rationale from the system's perspective. For tumors under 2 centimeters, the risk of waitlist dropout is generally low, but the rate of false positive diagnoses on imaging is actually relatively high.
Oh, so they might not even have cancer.
Right. The transplant committee cannot risk giving away a scarce life-saving organ for a tiny spot that might turn out to be a benign nodule rather than aggressive HCC.
Which puts an unbelievable, almost unimaginable amount of pressure on the radiologist reading that scan. If we are talking about a threshold of exactly 2.0 centimeters, the margin for error is effectively zero.
Zero margin. If we connect this to the bigger picture, you can see why meticulous radiology is the linchpin of this entire operation. A measurement being off by just 2 millimeters completely derails the algorithm. If a radiologist hastily measures a 1.8 centimeter tumor as 2.0 centimeters, they might push a patient into surgery for a false positive.
And if they measure a 2.1 as a 1.9,
they deny a dying patient a liver. That single millimeter dictates everything.
That is a staggering amount of responsibility, and it begs the question, how do you even get an accurate millimeter-perfect measurement when the organ you were looking at isn't standard? Because the diagrams of the liver we all saw in high school biology are basically a lie.
A total fabrication for the sake of simplicity.
Yeah, textbooks show this one perfectly symmetrical diagram of the liver's plumbing. But the Stanford and Tri-Service data reveals that reality is vastly different. How many people are walking around right now with abnormal liver plumbing?
The myth of normal anatomy is something surgical residents have to unlearn very quickly. Up to 40% of the population has variant plumbing in their liver.
40%. That is almost half.
It is massive. The liver is not a uniform block of tissue. It is a highly complex, customized filtration plant. Let's look at the portal vein, for instance. This massive vein provides about half of the liver's oxygen and transports all the nutrients and toxins straight from the gastrointestinal tract. In a textbook, the main portal vein splits neatly into a left branch and a right branch, but about 20 to 35% of patients have variations in that primary split.
And one of the most dangerous variations highlighted in the review is the Z-shaped variant, which shows up in about 13% of people. What exactly does a Z-shaped variant look like, and why is it such a trap for a surgeon?
In a Z-shaped variant, instead of a clean left-right split, the main portal vein bifurcates into the right posterior pedicle, which is the main supply line for the back right section of the liver, and then a shared trunk that feeds both the front right section and the entire left side. On a scan, this tangled junction looks like the letter Z. It is a critical trap because of how hepatectomies or liver resections are performed.
Right, because they have to tie off the blood supply.
Exactly. If a surgeon is removing the left side of the liver, they need to ligate or tie off the left portal vein. If they unknowingly tie it off at its origin in a Z-shaped variant, the consequences are disastrous.
Let me try to put that in perspective for you. Imagine you are trying to cut the power to just your kitchen so you can safely fix a light switch. But because the electrical wiring in your house is a rare Z-shaped variant, flipping the breaker for the kitchen accidentally shuts off life support to the entire house. By tying off that vein in the liver, the surgeon isn't just isolating the left side, they are completely cutting the blood supply to an entirely healthy right anterior sector. The patient loses a massive chunk of healthy liver tissue for absolutely no reason.
That analogy is spot on. And the surprises aren't limited to the portal veins. The arterial system is just as unpredictable. About 15 to 16% of patients have variant right or left hepatic arteries. A patient might have what is called a replaced right hepatic artery, which completely bypasses the normal route and pulls blood all the way from the superior mesenteric artery, which is a major vessel usually dedicated to the intestines.
Wow.
And the outgoing veins, the ones draining the filtered blood back to the heart, they have their own quirks too. Up to 40% of people have an accessory inferior right hepatic vein.
So almost half the population just has a bonus vein draining directly into the inferior vena cava. But finding that extra vein on a scan isn't just a fun piece of trivia for the medical chart. How does knowing about that extra drain pipe change the game for the patient.
What's fascinating here is that spotting this extra vein opens up completely new, highly targeted surgical options. The liver is divided into 8 distinct segments. If a surgeon knows this accessory vein is present, they might be able to perform a precise bisegmentectomy, removing 2 specific segments while sparing segment 6 entirely.
Because segment 6 has its own drainage.
Exactly. They can leave segment 6 behind because they know it has its own private drainage system via that extra vein. On the flip side, if an interventional radiologist is performing Y90 radioembolization, where they drop microscopic radioactive beads into the liver to nuke a tumor, they absolutely must know if that extra vein is there.
Because if they don't map that extra vein and they don't temporarily plug it before dropping the beads, that radioactive material isn't going to stay in the liver. It will flush right out of that bonus drain pipe and shunt straight into the patient's lungs.
That is the exact danger. It causes severe lung toxicity. And we haven't even touched on the biliary tree, the intricate network of ducts that carry bile out of the liver. The medical community uses the Huang classification system to map these variations.
Right, the Huang system.
Yes, if a patient has an aberrant right posterior duct that happens to drain into the left side of the system, and a surgeon snips it by accident because it wasn't on the preoperative map, it leads to catastrophic bile leaks inside the abdomen, severe infections, and potentially total liver failure.
This is why modern imaging is so miraculous. The CT scans and MRIs aren't just pictures, they are the ultimate treasure maps. The clinical data notes that CT is often better for spatial resolution and it's faster, which avoids the blurry motion artifacts that happen if a patient has ascites.
Which is a buildup of fluid in the abdomen common in liver disease.
Right. But MRI seems to be the gold standard for mapping the biliary tree, specifically when using a contrast agent called gadoxetate sodium. Let's decode that for a second because it's pretty cool. How does that contrast agent actually work?
Gadoxetate sodium is brilliant. Standard contrast dyes just float in the bloodstream to highlight blood vessels. But liver cells actually absorb gadoxetate sodium and actively pump it into the bile ducts.
It's like a functional test.
Exactly. It is the equivalent of pouring a harmless glowing neon dye into a river system just to watch exactly where all the tiny hidden tributaries flow. It gives the multidisciplinary team a flawless 3D blueprint to navigate all these anatomical traps before a scalpel ever touches the skin.
So what does this all mean if a patient comes in, they have a massive tumor, their anatomy is perfectly mapped with the neon dye, but their liver is heavily damaged by cirrhosis? Because you can't just cut out half the liver if the half you leave behind isn't strong enough to keep them alive. That brings us to one of the most mind-blowing sections of our research, the concept of the FLR, or future liver remnant.
The future liver remnant is the exact volume of healthy, functioning liver tissue that will remain in the body after the surgeon removes the tumor. For a completely healthy person, say someone getting into a car accident who needs liver surgery, you only need to leave behind about 20% of the organ. It is incredibly resilient and will regenerate.
Right, the liver grows back.
Yes. But HCC almost exclusively develops in cirrhotic scarred livers. For a patient with cirrhosis, that 20% isn't enough to filter the blood. You need to leave behind 40 to 50% of the liver because the tissue is fundamentally compromised.
But what if they don't have that 40 to 50%? What if the tumor is so big that removing it leaves only 30% of the liver? Historically, that patient was just sent home. But now doctors have developed techniques to literally force the healthy part of the liver to grow before they do the surgery. It is pure physiological biohacking. How do they trigger that growth?
The medical term is inducing hypertrophy. The most established method for doing this is called portal vein embolization, or PVE. Interventional radiologists go in and intentionally block the portal vein, supplying the side of the liver that has the tumor. The body immediately panics. It senses the blockage and reroutes all that nutrient-rich, oxygenated blood to the healthy side of the liver.
Like diverting a river.
Exactly. Over the course of about 4 weeks being force-fed, all those extra nutrients causes the healthy side to grow rapidly, bulking up until it hits that 40 to 50% threshold required to safely sustain the patient.
And from the data, the complication rate for PVE is remarkably low, only around 2.2%. It's a very safe procedure. But science didn't stop there. The review outlines a newer, much more intense version called LVD liver venous deprivation. With LVD, they aren't just blocking the incoming blood.
No, they take it a step further. With LVD, they plug the incoming chordal vein, but they also plug the outgoing hepatic veins on the tumor side. They lock the front door and the back door. This completely halts the blood flow dynamics on that side, which forces an even faster, more dramatic growth of the healthy remnant on the other side.
But wait while you're waiting 4 weeks for the healthy side of the liver to bulk up what is happening to the cancer. Doesn't the tumor just keep growing too?
That is the constant race against time. If tumor progression is a major concern, doctors utilize radiation lobectomy. This brings us back to yttrium-90, or Y90. It's a brilliant dual-action technique. The interventional radiologist injects the Y90 radioactive beads into the tumor side.
So they are treating it and growing the other side.
Precisely. The radiation simultaneously nukes the tumor, stopping it in its tracks while intentionally injuring the surrounding tissue on that half of the liver. The body responds to that localized radiation injury by commanding the healthy side of the liver to grow and compensate. It is a slower process, taking 6 to 9 months for the healthy side to bulk up, but it keeps the cancer totally suppressed while you wait.
But if a patient's tumor is wildly aggressive and they need that healthy liver growth immediately, there is one final extreme option. It is called ALPPS. That stands for Associating Liver Partition and Portal Vein Ligation for Staged Hepatectomy. That is a massive mouthful. Basically, it is a highly aggressive, two-stage open surgery. The surgeon literally goes in, physically splits the liver in half along the planned resection line and ties off the portal vein to the tumor side. Leaving the liver physically traumatized and split induces massive explosive growth of the healthy side in just 1 to 2 weeks.
It is a phenomenal feat of human physiology, but it comes with a massive caveat. ALPPS is intensely invasive. Because you were performing major surgery twice in a matter of weeks, the morbidity rate jumps to around 35% compared to the 2.2% of a standard PVE. It's a high-risk, high-reward option strictly reserved for highly specialized medical centers.
Just pause and think about that for a second. We have the medical technology to literally remodel an organ inside a patient's body. We are directing blood flow to sculpt a brand new liver so that an impossible surgery becomes possible. But as incredible as that is, the cancer is always fighting back. Tumors are incredibly adaptive. If you block a tumor's main blood supply from the inside of the liver, does it just give up and die?
Unfortunately, no. Tumors are masters of survival. If you starve them of their primary blood source, they will send out chemical signals to build new blood vessels. They will track down backup generators. This is known as extrahepatic supply. The data shows that between 17 and 27% of patients have liver tumors that are pulling blood from vessels completely outside the liver.
It reaches outside the liver.
Yes. For instance, if a tumor is located near the dome of the liver right up against the diaphragm, it will often reach out and hijack the right inferior phrenic artery to feed itself.
Which means if the interventional radiologist only maps and treats the arteries inside the liver, the tumor just switches to that inferior phrenic backup generator and survives the treatment. They have to hunt down and plug those sneaky outside vessels too. But what happens when locoregional therapies, the targeted beads and targeted plugs, just aren't enough? What if the tumor has grown too large or invaded too deeply?
This is where the landscape of oncology is completely transformed over the last few years. Historically, if a patient had advanced unresectable HCC, they were given a pill called sorafenib, and the overall survival outlook was frankly grim. But thanks to 2 massive clinical trials mentioned in our data, the UMBRAVE 150 and the Himalaya trials, first-line systemic therapy has evolved. Doctors are now seeing dramatic responses using combinations of immune checkpoint inhibitors and VEGF inhibitors. We are talking about drug regimens like atezolizumab bevacizumab or durvalumab tremelimumab.
Okay, let's decode that cocktail for a second because it is fascinating. An immune checkpoint inhibitor basically acts like a key that unlocks the brakes on the patient's own immune system, allowing the body's natural T cells to finally recognize and attack the cancer. And the VEGF inhibitor cuts off the tumor's ability to build new blood vessels. So you are simultaneously starving the tumor of its infrastructure while sending the body's fully armed immune system in to finish the job.
That is the exact mechanism, and the results are truly paradigm shifting. But as always in complex medicine, there's a vital safety caveat. The VEGF inhibitor component, the part that stops blood vessel growth, inherently increases a patient's risk of bleeding. Because these patients usually have severe cirrhosis, they are already at high risk for something called clinically significant portal hypertension, or CSPH.
Because the cirrhotic liver is so severely scarred and stiff, the blood trying to enter the liver hits a wall. The pressure backs up into the rest of the body, and the blood has to find detour routes. It creates these swollen, incredibly fragile veins called varices, usually lining the esophagus or the stomach.
Precisely. And those fragile varices are a ticking time bomb. Radiologists must rigorously hunt for these signs of backed-up pressure on the imaging. If a patient has mucosal esophageal varices, those veins must be endoscopically banded.
Banded like with rubber bands.
Yes. A gastroenterologist goes down the throat with a camera and essentially ties tiny rubber bands around those swollen veins to choke them off and prevent them from bursting. This absolutely must happen before the patient can safely start the atezolizumab bevacizumab therapy. If you miss the varices, start the drug, and increase the bleeding risk, the patient could suffer a sudden fatal hemorrhage.
But when all these steps are followed and the treatment works, it is nothing short of miraculous. The AJR review included this remarkable visual case study that I can't stop thinking about. It was a 44-year-old man. He had a massive advanced stage HCC that had literally grown out of the liver and into his inferior vena cava. It was invading the main massive vein, returning blood to his heart.
Which is usually terminal.
Right. Historically, seeing a tumor inside the vena cava is a devastating terminal diagnosis. But they started him on the atezolizumab bevacizumab regimen. After 16 cycles of the therapy, the tumor components inside the vein completely resolved. The imaging went from showing a blocked invaded vessel to a perfectly clear open vein. The systemic therapy just melted the invasion away.
It is incredibly humbling to see that kind of systemic response, especially for a cancer that has been notoriously resistant to systemic chemotherapy for decades. It completely changes the tone of the conversation an oncologist has with a patient facing advanced stage disease.
So to pull all of this together, look at the immense journey we've taken today. We started with the agonizing wait and not ablate paradox, exploring why the medical system holds off on treating a 1.6-centimeter tumor just to secure a spot on a transplant list. We navigated the hidden, dangerous Z-shaped anomalies in the liver's plumbing that could trick a surgeon into removing healthy tissue. We broke down the biohacking of the future liver remnants, starving one half of an organ to force the other half to regenerate on command. And we finished by witnessing modern immune therapies melt away advanced tumors that had invaded major blood vessels. It is a brilliant testament to how fast the entire field of radiology and oncology is moving.
It really is. And this raises an important question for you to ponder as we wrap up. We discussed how doctors looked for physical downstream clues, like swollen esophageal varices or fluid in the abdomen, to know if the pressure inside the liver is dangerously high. The clinical definition of that danger zone is a hepatic venous pressure gradient of 10 millimeters of mercury or more. But right now, measuring that actual pressure directly is incredibly invasive, requiring catheters threaded into the liver itself. So doctors rely on looking for the physical damage on a scan instead.
Which means the damage is already done.
Exactly. So consider where we are. In an era where we can map a millimeter-wide aberrant bile duct in brilliant 3D neon dye, and we can biohack an organ to physically grow on command, why are we still waiting for downstream physical damage to tell us the pressure is too high? What if the next massive frontier isn't just mapping the physical anatomy, but inventing a completely non-invasive way to measure the invisible physics and pressure inside the liver before the damage is ever done?
That is exactly the kind of question that drives the next major medical breakthrough. Thank you for joining us on this deep dive into the hidden world of the human liver and the incredible technology working to save it. Keep exploring, keep asking questions, and never stop being curious about the world around you. We will catch you next time.